Namaste everyone, this is Dr. Harshvardhan from Vice Academy. So this video will be seeing 25 MCQs. Recently conducted the quiz at sogus, Telangana and Andhra Pradesh. I hope you enjoy solving the MCQs. First I will present the questions and then followed by the key for discussion. Hi friends, this was a quiz I conducted at August 2024. So we have 25 MCQs. Each question carries 4 marks. Correct answer you will be awarded 4 marks, and for each wrong answer you will get 1 negative mark. Idea is to learn 25 new points at the end of this quiz. Question number 1. Which of the following statements is correct regarding calcium supplementation in a patient who is labeled as a recurrent stone former? Option A. Calcium should be avoided in recurrent stone formers. Option B. Calcium should be supplemented with food. Option C. Can be given up to 50% of the dietary allowance. Option D. Low calcium diet is recommended to avoid recurrence of stones. Second question. Which of the following is least useful modality in the management of matrix stone in the kidney? Option A. RIRS. Option B. Laser. Option C. PCNL. Option D. ESWL. Question number 3. What is the length of 032 Termo guide wire which is commonly used in day-to-day urological procedures? Option A. 150 centimeters. Option B. 75 centimeters. Option C. 250 centimeters. Option D. 125 centimeters. This question is pertaining to C-arm interpretation. Question number 4. When the C-arm is rotated towards the surgeon during PCNL, which of the following statement is correct? Option A. Superficial calyces move away from the spine. Superficial calyces move cephalad. Superficial calyces move towards the spine. Superficial calyces move caudally. Question number 5. Identify the procedure that is being done for BPH. This is a video which I have downloaded and borrowed from iKnew surgical videos. Observe the video carefully and see what the surgeon is doing, and then I will show you the options. This is the end of the procedure. Option A, CUNA. Option B, TUIP. Option C, Eurolift. Option D, resume or reason. Question number 6. Watch this video carefully. This is a young male who was having infertility issues. So prior to IVF, this procedure was done. Identify the procedure which was shown in the video. Option A, PISA. Option B, TISA. Option C, micro TISA. Option D, TESI. Question number 7. What is the size of the nephroscope used in microperc PCNL? Option A, 4.5 French. Option B, 0.9 mm. Option C, 3 French. Option D, 9 mm. Question number 8. Observe the image carefully. You can see the red color encircled area where the pathology is. What is the best endoscopic management for this condition given in the image? Option A. Give an incision on the lesion on the medial and inferior edge with the bladder empty. Option B, give an incision on the lesion on medial and inferior edge when the bladder is full. Option C, give an incision on the lesion on the lateral and inferior edge when the bladder is empty. Option D, give an incision on the lesion on the lateral and inferior edge with a full bladder. Question number 9. This is an elderly man who comes to OPD with acute retention of urine due to BPH. Which is a catheter that should be used? Option A, 14 French straight tip. Option B, 14 French curved tip. Option C, 18 French straight tip. Option D, 18 French curved tip. 10th question. What does the numbers 445 as shown in this rigid cystoscope represent? Option A, size of the stent that can be passed. Option B, number of working channels in the sheath. Option C, sizes of the working channels with respect to the bridge that is used. Option D, size of the feeding tube that can be passed through the channels. Question number 11. Which of the following is a oral GnRH antagonist receptor recently approved by FDA for management of advanced prostate cancer? Option A, Degarelix. Option B, Relugolix. Option C, Abiraterone. Option D, Abarelix. Which of the following is most useful movement in RIRS while dealing with a stone in the left middle calyx? Usually the surgery is done by a right-handed surgeon. Option A, up and down movement. Option B, back and forth movement. Option C, flexion or internal rotation at the wrist. Option D, extension or external rotation at the wrist. Question number 13. Which of the following procedures requires a safety guide wire for a safe surgery? Option A, PCNL. Option B, URSL and PCNL. Option C, RIRS and URSL. Option D, URSL, RIRS, PCNL. Question number 14. While doing Anderson-Hines pyeloplasty, what is the site where the ureter should be spatulated? Option A, medial. Option B, lateral. Option C, anterior. Option D, posterior. Question number 15. Which of the following is most likely to be a posterior calyx? This is a RGP image which has been done in supine position. See the image carefully and identify the posterior calyx in this image. The numbers are marked there, 1, 2, 3, and 4. Option A, 1. Option B, 2. Option C, 3. Option D, 4. Observe the image carefully. This is an intraoperative image where a hypospadias repair is being performed. Identify or name the test by which you can assess the degree of ventral curvature. Whittaker test. Option B, Gitti's test. Option C, Boni's test. Option D, Gillette test. Question number 17. This is pertaining to technique of TURP resection. During this procedure, the gland is resected from 11 o'clock to 9 o'clock and then from 1 o'clock to 3 o'clock. What is the technique of TURP? Option A, May and Hertang's procedure. Option B, Barnes procedure. Option C, Nesbitt's procedure. Option D, Alcock's and Flock's technique. 18th question. In a case of left undescended testis, the following are the laparoscopic findings. There was a blind ending vas at the internal ring, and the testicular vessels could not be identified. What is the next best thing to be done? Option A, inguinal exploration. Option B, abandon the procedure and perform an MRI. Option C, search retroperitoneum up to the lower pole of kidney. Option D, it's a case of vanishing testis and nothing to be done. Question number 19. See the CT image below. It is a case of emphysematous pyelonephritis. What is the grade of EPN shown in this image according to Hyon-Sang classification? Option A, grade 1 EPN. Option B, grade 2 EPN. Option C, grade 3 EPN. Option D, grade 4 EPN. Question number 20. Which of the following is not correct regarding intravesical instillation after TURBT? Option A, mitomycin should be given within 6 to 24 hours after TURBT. Option B, mitomycin prevents disease progression better than BCG therapy. Option C, BCG acts as an immunotherapeutic agent. Option D, URTC regimen is followed for BCG instillation. Question number 21. Which of the following settings is recommended for best popcorn effect with laser settings with laser during RARS? Option A, high energy, low frequency. Option B, high energy, high frequency. Option C, low energy, low frequency. Option D, low energy, low frequency. 22nd question. Which of the following is not a nephrolithometry scoring system? Option A, Guy's scoring system. Option B, Crow's nomogram. Option C, Cutton nomogram. Option D, Stone nephrolithometry. Question number 23. Which of the following mutations is commonly linked with low-grade papillary bladder neoplasm? Option A, RB gene. Option B, P53. Option 3, FGFR3 mutation. Option D, PTEN gene mutation. Question number 24. Which of the following option most common nerve which is injured during psoas therapy, psoas surgery during Bowery flap creation? Option A, obturator nerve. Option B, femoral nerve. Option C, genitofemoral nerve. And option D, ilioinguinal nerve. Question number 25. This is a case of purple urine bag syndrome. Which of the following is correct regarding purple urine bag syndrome? Option A, the most common organism responsible is Citrobacter. Option B, it is a medical emergency which is suggestive of urosepsis. Option C, it is usually seen after intravesical BCG therapy. Option D, it's a benign condition. Replace the catheter and treat with culture-specific antibiotics. Thank you. I will disclose the key in the next video. So I hope you have enjoyed answering the questions. Now we will resume with the key. So I'll try to give a detailed explanation. So regarding this calcium supplementation, it should be given with food. There's a beautiful article, even in Campbell also. This is a NEGM article. You can see they have done a randomized controlled trial where they have found out that persons who are on low calcium diet have the highest risk of going into recurrent or forming recurrent stones. So based on this, they found out that it is better to give a normal calcium diet, and the ideal time of supplementing calcium is with the food, because the calcium now binds with oxalate and is excreted in stool. If you are again spacing calcium and oxalate two different times, then the oxalate excretion is impaired. It may land up or show up at the genitourinary system and stones recur. So least useful is ESWL, because soft stones, it is very difficult to deal with ESWL, and followed by RIRS also was not a great modality for management of matrix stones, but of late with the onset of new device like the fan suction device, you can pull out the matrix stone. But the best one would always be a PCNL, because it also gives adequate drainage. So this is a straightforward. Now go back and see the thermo guide where you will find out that it is 150 centimeters. And the flexible length is 3 centimeters. The total length is 150 centimeters. 250 centimeters, usually this cardiology suits will have 250 centimeters guide wire. So this is very important. You have to understand what happens when the CM moves towards you or away from you or towards the head end. If you try to remember that, you can master the art of PCNL. So when you are trying to move the CM towards you, if something is moving away or towards the spine, it means that that is superficial. Let us say if you are trying to puncture, if your puncture needle is moving towards the spine, it means you are superficial to the desired target. If a calyx is moving towards the spine, it means it is a superficial or anterior calyx in supine PCNL, or it might be a posterior calyx in prone PCNL. That is how you should be interpreting. So this is a straightforward. If you see this, if you have seen this, you can answer it. It is prostatic urethral lift. So resume is a different
The
procedure.
Eurolift system is a new.
Resume is a water vapor therapy. This video you have seen, in this video, they are trying to extract the sperm, and this procedure is called TSA, testicular sperm aspiration. If you are doing it from epididymis, then it is called PSA, percutaneous epididymal sperm aspiration. So microperk, yeah, the size of the sheath is 4.5 French, and the size of the telescope or nephroscope that we use is 0.9 mm. So this is the reference. These references are taken from Smith Endourology. It's a wonderful book for endourology. If you have not started reading the Smith Endourology, start reading. So this is again taken from Smith Endourology. So by this time, we will understand this is a case of bilateral uretrosil and patient complaints on the right side. So right side pathology, two key points here. Incision should be given when the bladder is empty or at least partially filled, so that the uretrosil beautifully pops out and it is tense. And the incision should be given from the medial aspect of the inferior ridge, a smiling incision. You can see here. If you are giving a lateral to medial incision, there is a chance that sometimes we overzealously go and hit the other ureteric orifice. To avoid that, a medial to lateral incision is suggested, and it should be given in empty bladder, because the bladder will be tense, the urethrosil will be tense, and your incision will be finished in a single stroke. So best catheter is, this is straightforward question from Campbell. So curved catheter is useful because it will negotiate through the prostatic urethra. A large prostate will not allow a smaller catheter because of buckling thing. So vice versa is for stricture urethra, where you have to use a smaller size ureteric catheter or infant feeding tube to negotiate into the urinary bladder. So this instrument you daily use for cystoscopy, stent removal, everything. So whatever instrument you are holding from now on, grab the instrument and see what are the markings on that instrument. You have these markings on mini perk, nephroscope, ureteroscope, everywhere. So this is the number this is the number which tells that if you are using a single bridge, a 5 French instrument can be passed, be it a grasper or a stent removal grasper or a stent or whatever electric catheter, whatever it is. But if you are using a bridge which is having dual channel, then A 4 and 4 French sized instrument only can be passed through it. So that is about the working channel. This is again taken from Campbell textbook. So GnRH antagonist, it is relugolix. It's a new drug. Already many of the pharma companies are marketing. So the advantage is obviously less expensive than a Degarelix. And second point is oral medication. So the chance of having the side effects of injection pain and all this will be very less when compared to Degarelix. So there are wonderful videos in Pure Urology and also in INU and also in lot of videos in YouTube where you can see the how to handle the flexible ureteroscope. So see this, if you are rotating it inwards, the tip flexes to the opposite side. If you are rotating it outwards, the flexes to the right side. So when you want to see a left side kidney, you are doing an internal rotation. So the tip of the flexible scope negotiates into the middle calyx beautifully. From there, if you want to go up, down, all these maneuvers you can do. But overall, of the given options, the best option would be flexion or internal rotation at the wrist joint, which will allow you to see the middle calyx of the left kidney. So safety guide wire for all surgeries, safety guide wire is used. It should be used. And in one of the presentations by Dr. Oliver Traxler, he says, I am a humble person. I've done so many RIRs, but still I use a safety guide wire. So Anderson Heinz pyeloplasty, always at the time of giving a incision, we try to recollect that at least I have been, I used to do in early days of my PG and also in my practice. So as you keep increasing the numbers, you will, it goes into the subconscious level. But as a resident, you should know that the incision is given on the lateral side. This is again taken from Campbell textbook. Just go back and read this topic from Campbell textbook. Why lateral incision? To avoid interrupting to avoid, see, the vasculature blood supply comes from medial to lateral. So if you are giving a medial incision, there is a chance that you will jeopardizing the vascular supply to the ureter. So preferably you give a lateral incision. This again from Campbell textbook, but a clinically related stuff. So you can see that it is done in supine position, already given in position, and also you can see a flexible scope. So obviously it is a supine RGP. So in supine RGP, the calyces which are posterior appear to be dark. So of the given options 1, 2, 3, and 4, the second option is more likely to be a posterior calyx. And the second option, if you closely observe, is round and spherical. According to, if you see the Sampier classification given in wonderfully in Smith Endourology, chapter 4 or 5, you can understand the orientation of anterior and posterior calyces. I will suggest you to read the topic from Smith Endourology. It's a wonderful topic there. You will understand the orientation of calyces. So it will make your life easy when you are trying to puncture and gain access to PCN in PCNL. So the answer is 2 here. So this is a straightforward question. This test is done by injecting normal saline. So this will create a erection, artificial erection. So this will help us to know the amount of ventral curvature, if it is less than 30 degrees or greater than 30 degrees. Based on that, we proceed for cardiac erection. So to assess that, they use an instrument that is called goniometer. And the name of the test is Gitti's test. So TRP, this is very, very important because we do it in a day-to-day basis. So common techniques used are Barnes and Nesbitt's. Barnes starts resecting from the median lobe. First, they take prophylactic control of the 5 and 7 arteries, and then the resection of the median lobe, and then go to the lateral lobes. In Nesbitt's technique, it is a kind of enucleation resection. Now, Nesbitt's technique is gaining more popularity because of enucleation techniques are now in more vogue. It got into vogue. So enucleation, it starts from 12 o'clock or at least from 11 o'clock. It moves to the 9 o'clock. The whole lateral lobe falls down. Again, now they go back and again from 11 o'clock or 1 o'clock, they start resecting up to 3 o'clock. So now both the lobes fall inward and the vascularity of the lobes is cut off. So it will be a beautiful bloodless surgery. So the technique here asked is Nesbitt's technique. So this is image from Campbell. But if you want to still understand what is Nesbitt and Barnes technique, there are two beautiful videos. One by Dr. Madhusudan Agarwal. I have shared the link. It is in pure urology, and a modified Barnes technique by Dr. C. Mallikarjuna. You can see in Ainu videos. I have shared the links here. You can go and try to understand the techniques of TURP. So this is a straightforward question, again taken from Hinman. So the idea is you should understand what are the different things that can happen, especially when you are trying to deal with a undescended testis. Here, they are given two important points. One is VAS is present, which is blind ending at the level of internal ring. Second one is testicular vessels could not be identified. So it means that some testis is somewhere. So what next? Testis we know descends from the uh, retroperitoneum into the scrotum. So a thorough explanation to the retroperitoneum with the reflection medialization of the colon up to the lower pole of the kidney should be done. So these are the 7 scenarios that can happen in a case of undescended testis. Straightforward. Uh, right side, it's a completely gone 3B, 3B EPN. On the left side also, you can see patchy emphysematous pyelonephritis. As it is a bilateral condition in this scenario, it is grade 4 EPN. So TRBT, mitomycin is usually given for low-grade tumors, and BCG therapy is given for intermediate to high risk, high grade and high risk tumors. So multiple studies have proven that BCG induction followed by maintenance with either a SWOG or EORTC regimen will definitely help in preventing recurrence, also preventing disease progression. But with mitomycin, when they compared vis-a-vis with BCG installation, they found that it only prevents recurrence, but progression of disease is not under the control of mitomycin intravesical therapy. There are other drugs like gemcitabine, valzubicin, especially valzubicin is given in BCG refractory therapy. So these things are commonly asked for your Viva and also for day-to-day practice. So popcorn effect, to be honest, when I also was using a different kind of settings. Mm, Off late, after watching some videos, I came to know that my settings of popcorn was not correct. That's why I put this question. So the answer is high energy and high frequency. I used to do it in low energy and high frequency, but off late I have been doing it with high energy, high frequency. It's a clear-cut line taken from Smith Endourology. Just go back, as I said, Endourology, Smith is a wonderful book. Start reading it. So this is from one of the presentations given in our conference where you can see popcorn. They're using long pulse, high energy and high frequency. So scoring system for Viva OC they will ask, and also this will also, if you try to inculcate the habit of using IIEF, IPSS and these kind of scoring systems in your day-to-day practice, the way you can counsel the patient will be much easier. You can address the complexity of the situation to the patient, and also you can have a fair idea on how complicated this case is going to be. Same thing with partial nephrectomy scoring system. These things are mandatory for a postgraduate to done before giving the exam. So cut and nomogram is for carcinoma prostate. Again, you can see this wonderful slide from Smith Endourology. This one is straightforward from Campbell Urology. The answer is FGFR3. Baki all mutations are associated with muscle invasive and high-grade tumors. So most common nerve injured during psoas itch, the genitofemoral is injured, femoral nerve is injured, lateral femoral cutaneous nerve, these three can be injured, and this is called a psoas syndrome. And ilioinguinal nerve injury is at the time of architectomy, and obturator nerve injuries occur when performing pelvic surgeries. But the most common here that can happen is a genitofemoral nerve injury. So this is a very rare case, purple urine bag syndrome. It is a multifactorial, usually seen in elderly female, constipated, multiple laxatives, and added to it, there is some alterations in the tryptophan metabolism. So it's a very benign condition. All you need to do is need to change the urinary catheter and put the patient on culture-specific antibiotics. It is due to interaction between all these situations with a set of bacteria like Pseudomonas, Proteus, E. coli. So it's a benign condition. All you need to do give reassurance and put the patient on antibiotics and change the catheter. That would deal with the situation. So I hope you have enjoyed the session. Any queries, you can feel free to contact me or Dr. Kaushik on Vice Academy. All the very best. Thank you.